Hello, I'm Mark Sawyer, a pediatric infectious disease specialist on the faculty of UC San Diego. For the past several years, our medical school has been working with public health departments to improve national immunization levels. One of the things we often hear from physicians is that they want to make sure they and their staff receive enough training in giving immunizations. This video is an answer to that need. Immunization experts from around the country have worked together to develop the video you are about to see. It deals exclusively with the skills and techniques needed for safe, effective, and caring injection of vaccines. It is intended for anyone who provides immunizations to children or adults.
Hello, I'm Natalie Smith. Welcome to this video course on immunization skills and techniques. The video and the skills checklist can be used for training new employees during their orientation or probationary period. It can also be used for staff for performance improvement relating to immunizations and as a refresher for all other staff who administer vaccines. Ultimately, the medical director, doctor, or designated supervisor is responsible for the training and competency of staff. This video is only one tool.
The content will be covered in 3 segments. First, we will present the basics of preparing and giving immunizations. Next, we will show demonstrations of proper technique on children and adults. And these demonstrations will serve as a visual reference point or benchmark for the standard of care in giving immunizations. It is critical that staff administering immunizations routinely receive training in safe injection practices. So we will conclude with a discussion of training and competency and how to review your own or your staff's performance in immunization on a regular basis. Our content is based on the national standards for immunization practices, the published recommendations of the ACIP, and the American Academy of Pediatrics. But it is augmented with best practices and tips from doctors, nurses, and medical assistants who give immunizations every day. We hope you find this video to be a valuable training tool for new staff, as well as a refresher course for everyone in your practice who gives immunizations.
For many healthcare workers, giving immunizations is an everyday routine. And whether we are administering 5 immunizations to a child or just 1 to an adult, as a healthcare professional, we want to do it right. We want to administer each immunization safely. We want to do it properly so the vaccine protects our patient. And today, when our patients could be scheduled for 3, 4, or 5 shots, more than ever before, we want to do it with empathy and caring. We believe the techniques demonstrated in this video are the most effective and least painful to the patient. They will help you make vaccine delivery as safe, effective, and comfortable as possible. If you are new to immunization, this video will provide you with the background knowledge you need before you receive your supervised, hands-on training. For others, we hope it gives some additional information to help you improve and maintain your skills and provide a visual reference point for ongoing self-assessment. Because we are covering just immunizations, not injections in general, we are limiting discussion to only the most common intramuscular and subcutaneous routes of administration, and to those anatomic sites and needle sizes specifically appropriate for vaccines. We will not be discussing immune globulin, less routine vaccines, or TB skin tests. Why do we worry so much about the right anatomic site and the right length needle? Because the effectiveness or efficacy of the vaccine depends on using the proper site, the right needle, and the proper route. An intramuscular vaccine is intended for the muscle. Vaccine injected deep into muscle tissue is absorbed efficiently and gradually into the bloodstream. But when a vaccine that should go into the muscle is deposited in subcutaneous tissue instead, efficacy is compromised. The parents may think their child is protected. Your chart may show the child was immunized, but in reality, the patient has been left susceptible because the shot was given improperly. What a waste of expensive vaccine and with such potentially tragic consequences. Such errors can also cause unnecessary side effects for the patient, like painful local reactions. Using the proper site, needle, and route also will diminish the pain often associated with injections. We administer most vaccines by the intramuscular route, including DTaP, hepatitis A and hepatitis B, Hib, influenza, and pneumococcal conjugate. Both IPV and pneumococcal polysaccharide can be given either by the IM or by the sub-Q route. We use anatomic sites that minimize the risk of local, neural, vascular, or tissue injury. The two muscles routinely used for intramuscular immunizations are the vastus lateralis and the deltoid, depending on the age and size of your patient. For infants and toddlers, the vastus lateralis in the anterolateral thigh is the preferred site for their intramuscular vaccines because of its lack of major nerves or blood vessels. Each patient is different, so before giving an IM injection, we need to expose the limb so we can evaluate where the muscle is and where the needle should enter. Each vastus lateralis easily can accommodate 2 IM injections. This site may be used for preschoolers as well as infants and toddlers. Providers who give immunizations regularly often get into a routine of injecting a particular vaccine, always in the same site and always in the same order. Here's what a vaccine site map for infants and toddlers might look like. As the site must be recorded on the patient's chart, always giving the hepatitis B vaccine in the left thigh, for instance, makes it easier to remember which vaccine was given where. Note that the buttock is not recommended for vaccines because the muscle there is thin and underneath it is the sciatic nerve. It should not be used for immunizations. For adults and school-age children, the deltoid is the preferred site for intramuscular vaccines. It is located approximately 3 fingers below the acromion, above the level of the armpit. Again, each patient is different, so we need to evaluate where the muscle is and where the needle should enter. Each deltoid can accommodate 2 IM injections. The deltoid also may be used in preschoolers if their deltoid muscle is well developed. The choice of needle depends on the volume and thickness of the fluid to be administered and on the amount of tissue to be penetrated. With vaccines, the volume of a dose is small, usually only a half cc. All the routinely recommended vaccines are suspensions, but comparatively thin fluids. These characteristics allow you to use a thinner 23 or 25 gauge needle. The higher the gauge, the thinner the needle. For intramuscular immunizations, a 1-inch or longer needle is needed to penetrate the subcutaneous tissue and deposit the vaccine into the muscle. Care must always be taken to ensure that vaccine is delivered deeply into the muscle. On a tiny infant or lean child, you could use a 7/8 inch needle, but this needle length is not in great demand and not commonly kept in stock. Use a 1-inch needle, even for a tiny infant. The more common 5/8 inch needle should not be used for intramuscular immunizations. Studies have shown a 5/8 inch needle is not long enough for an IM injection. For larger adults or obese adolescents, a longer 1.5 inch needle may be needed. If you touch the bone with the needle, simply pull back before depositing the vaccine. For IM injections, the syringe is held like a dart an inch away from the site and inserted quickly into the skin at a 90-degree angle. Now let's talk about subcutaneous immunizations. For sub-Q vaccines, we use a different site, a different needle, and a different angle because we are aiming for fatty tissue instead of muscle. MMR and varicella vaccines are administered by the subcutaneous route. Inactivated polio vaccine and the pneumococcal polysaccharide vaccine, used more commonly in adults, can be given either IM or sub-Q. The fatty tissue on the outer upper arm is the usual anatomic site for subcutaneous immunizations. For infants and toddlers, the fatty tissue on the outer